There's nothing to sneeze at tonight as On Call looks at allergies, what they are, and how to deal with them. The doctors are on call now.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together.
And which was healthier, the yogurt and the bagel?
Alright, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Blow hard! Blow, blow, blow! Keep pushing!
And try to take just your head.
Pull red handle to open bag.
Throughout the year, but especially in the summer and fall seasons, people suffer with allergies. The National Library of Medicine defines an allergy as a reaction of the immune system. People who have allergies often are sensitive to substances such as pollen, dust mites, mold spores, pet dander, food, insect stings, medicines. Allergies can cause a runny nose, sneezing, itching, rashes, swelling, or asthma. Symptoms vary, and although allergies can make you feel bad, they usually won't kill you, unless you have a severe reaction called anaphylaxis, which is a life-threatening scenario. Tonight, I'm very pleased to introduce to you our guests, Dr. Mark Bubak of Dakota Allergy and Asthma in Sioux Falls, and Dr. Tom Luzier of Aberdeen Asthma Allergy in Aberdeen. So thank you so much for being on our premier new Shift to Journalism show. Tell us a little bit about yourself, Mark. Let's start with you.
I'm actually a South Dakota native and did my training medical school right here in the state and at Mayo Clinic, and then came back, and I just love practicing here.
So you're a South Dakota boy, went to the Mayo, you practiced there, you trained there, you practiced there.
Correct.
Then you came back, and then you went back there for a while. Then you said, nah, I'm a South Dakota guy.
We love South Dakota.
So we're glad to have you here. And Dr. Luzier, you're an Aberdeen boy. Are you originally from Aberdeen?
I am not from Aberdeen, originally. I'm originally from Kansas City.
Oh.
And I grew up in Kansas City, went to a church school for undergraduate work, and then University of Kansas for medical school, and then served in the military for 12 years, active duty, in
Where were you?
Denver, Fort Riley, Kansas, and Fort Leonard Wood, Missouri.
So active duty in the States, though. This was before or after or in between any major...
Yeah, this is kind of the tail end of Vietnam. And at that time we had a lot of volunteer physicians, then we had conscription physicians, and then we had volunteer again, and so the number of physicians went down.
Were you a conscription physician or were you a volunteer?
I was a volunteer that would have drawn a number that would have made me a conscription. Yeah. So, yeah, but I was a volunteer at that particular time.
And you came to South Dakota what time?
I came in '87.
Now, you were a pediatrician at first.
Yes, and that's what I did in the military, and then trained outside of the military in a civilian fellowship, and then went back to the military to give back the time that I was in my fellowship, and then I left the military for reserve, and then went and stayed in Lawrence, Kansas for 2 years, and then moved to Aberdeen, because when you come to South Dakota, if you like to hunt and fish, you're not going home.
So that's it that drew you here.
No, yeah.
So we have a homebody and we have a hunter-fisherman. That's great. And you guys have both been here for quite a while. Mark, how many years? Practicing.
Practicing off and on since '92.
Tom?
87.
So experienced folks here. So we've got great opportunity to answer the questions. This is a show that we will not have phone-in calls, but we have good questions. And the first, but before we get into those, I thought it would be a good idea to start with our first package. So let's see what we have coming up here for a good story.
In the traditional way, these are some North American species here.
Professor Paul Johnson is an expert on bugs. He knows where they live, what they feed on, and how to precisely identify what they actually are. And he says, in the case of dust mites,
they're mites, and so they're small little creatures that are related to chiggers, related to ticks, and more distantly related to spiders. So they're not insects at all. They're eight-legged little critters.
It takes a strong microscope to get this good of a look at a dust mite. Generally, they're less than half a millimeter long, and you won't be able to see whether or not they're sharing your home with you.
They tend to be more abundant in bedroom situations and in carpeted situations. They're feeding on organic matter, the dust that accumulates in fabrics, in carpeting. So that can include anywhere that you have not only food particles collecting, but dander, skin pieces, fragments of hair, open, airy fabrics such as carpeting or loose linens tend to be really good places for dust mites to accumulate if they're not cleaned regularly.
Johnson can tell whether or not a bug will bite and feed on humans, and he says, in this regard, dust mites aren't much of a threat. Most allergic symptoms due to dust mites are caused by inhaling or somehow becoming exposed to proteins that are found within the dust mite body.
It's a combination of bites and exposure to the dead mite bodies, the fragments that we would breathe in or come into contact with on the skin. And that's where the cleaning, the things like shampooing carpets periodically or washing the linens comes in handy, so that you're removing those mite parts. They do bite, or they will, make temporary bite attempts, but they're really not feeding on you. It's more a matter of, they're just testing you out. There are no general use pesticides, for example, that are recommended for these. This is more a matter of managing the habitat, and in the case of a home, a reasonable effort at keeping the home clean. Frequent vacuuming, periodic shampooing if you're talking about carpets, making sure you're getting down along the corners and the edges there. It's really a lot of just normal cleaning of the house.
So that's a story about dust mites. Now, dust mites are not this seasonal type of a thing. That's this perennial allergy type of thing. So, Mark, tell me about your exposure to dust mites. How many cases do you take care of?
Dust mites like number 2 or so of the most common things to be allergic to, and we see numerous patients today. They have all year-round symptoms unless you keep your windows open, and it's nice and humid. You'll have a little bit more in the fall because of that. Terrible time with your nose or your asthma, and working hard at avoidance, we try.
Yeah. But you're telling me that it occurs a little bit more in the fall for dust mites because
of the humidity. We need to have our humidity down below 40, but if you're in 40 to 50% humidity, you don't get a lot of growth. But on these days with 80% humidity, the dust mites grow crazy if you keep your house open.
Oh, and so, the implication was that you should keep your house closed even though it isn't a seasonal allergy, it's the dust mites that's the problem. How many people come in the fall thinking that or in the summer, that they think that it's seasonal and it's allergy to dust mites?
I usually have about 4 or 5 a year. It was always great when you'd have somebody in training, a resident physician or something, and you could really bring that point in. I'm sure Dr. Luzier sees the same thing.
What's your response to that, Tom?
Well, the dust mite, the perennial allergen, number one is we're not really allergic to the dust mite. We're allergic to his waste product, which is actually he eats your skin cells and food particles and that kind of thing. So it makes it And the waste product is extremely light. So when you walk across your carpet, you actually kick the dust mite waste product up up into the air and inhale it. So dust mites create a very special problem for us. A is your pillow is a dust mite Hilton. Your stuffed animals are where they enjoy residence. And of course your mattress is. And they make barriers for your pillow and your mattress that are so tightly woven that the dust mite's unable to penetrate it, and so they can't lay their eggs and that kind of thing.
You've told me in other shows, and I mean both of you have been on this show for multiple times, but you've told me that this is a good thing, but I've read in a number of journals that that's not as effective as I had thought, and I kept thinking I needed to call you on that particular thing. Have you not read those same articles, or I mean?
We have read the articles, and again, it's a one tool. It's not a perfect tool. It's one tool. And when you take a controlled study and you make that the only tool, it's not as effective. But when you add
really, though, is that it works in people with hay fever, with an allergy nose. You can get the dust mites down enough to make a real clinical difference. But at least in South Dakota, it's really hard to impossible for asthma to completely fix it only with avoidance. You're going to need to do allergy shots or have medicine in addition to get the asthmatic control. That's a whole different level of severity.
Dust mites were studied in Italy, and originally it's kind of how they found out about it. And if you live in the lowlands, those people would be wheezing and have trouble, and then they'd be sent by their parents up into the mountains in the summertime. And their dust mite allergy would go away, and so would their asthma. So that was how they originally kind of got to understanding the effect of dust mites. For us as the allergists.
4 to 8 weeks in order to see that, though.
Exactly.
You can't just move out of your house for the weekend to see if that's the effect.
And see the effects.
Same thing with cats and dogs.
Other perennial antigens.
I have to tell you the story. We were in, what's that island where there's little tiny, there's no streets, Venice. So we were in Venice. My wife and I were traveling in Venice. And we were cheap college student kind of people. And so we found the cheapest hotel that we could, which was some guy's living room. And I swear 3 or 4 guests before us had died in that bed. I mean, it was so dusty. And I swear I didn't breathe for about 2 months after that particular visit in Venice. Funny that you would bring it up about being so dusty in the lowlands of Italy. Well, any take-home messages we should highlight about dust allergies? I mean, it seems to me, I mean, look at is it totally the dust mite poop? It isn't the dust parts, the mite parts or body parts, it's mostly the poop.
It's mostly the waste product. So that's something that, and people don't understand how light it is and how easy it is to aerosolize and how much of it gets into the, I mean, I'd still recommend to my dust mite allergic moms who are doing the majority of the vacuuming to mask when they vacuum. Or not vacuum, have somebody else do it.
The stuff's up in the air for about 2 hours.
When you walk across the room. Well, what about
especially the vacuuming?
Oh, the vacuuming. What about the carpeting versus bare wood floors?
Well, obviously the carpeting is going to hold that antigen, and it gives the dust mites somewhere to live. It's really hard to live on a wood floor because they have little hooks, and you can't suck them up with your vacuum cleaner because the animal is so light. It's not going to, you're not going to get enough suction on it. So it does hold that antigen in. So again, we recommend hardwood floors and the carpeting, and we like to see furniture that's not cloth because it harbors that antigen.
And one other comment about pillows. Okay, so pillows, I've often heard that, you don't want to do a feather pillow because they can really live in a feather pillow.
So that's a big myth.
That's a big myth.
Big myth, because actually feather pillows, because the little the ends of the down require a much tighter weave, and so they're probably preferable over some of the weave of the covering. But I still recommend coverings that's a microfiber
Actually,
covering.
tell people just get a new pillow once a year, because you just start from scratch again, and most everybody just rips the cover off of their pillow anyway, so you get better compliance and long-term effectiveness.
So just replace your pillow. That's the other thing to do.
Yeah.
And do you think foam pillows,
foam or whatever you want, you like, just as long as you change it frequently enough.
Change it frequently enough.
Now, one of the cool things that they do with dust mites, just for fun, is if you have children with stuffed animals and they can't get rid of this stuff. The nicest thing about South Dakota is 30 below is very good about getting rid of killing dust. So you can just take the animals out and freeze them, or you can put them in your freezer, but obviously 30 below is better than our freezer.
Yeah. Stick them outside for a
Stick them outside for a day.
And then you've cleaned up the act on
the live dust mite. You've killed the dust mite, so they're not producing any more
Fortunately,
waste.
there's not a lot in most people's stuffed animals. So you'd have to have really an old one with.
Oh, but a lot of them have.
Oh, and there's a lot of them that have like multiple.
Oh yeah.
Multiple dust mite Hiltons. Exactly. But the important takeaway. Dust mites are perennial. They're there all year long. And where it's really important to us is it keeps the immune system fired up all during the winter, independent of viral illnesses, that when spring comes along, now you're building on a platform of more allergy, so my spring allergy is going to be worse.
Yeah.
And so it's just going to build up, and each year it gets worse. And dust mite, cat and dog, the perennial antigens, are notorious for building that allergy up.
Yeah, I think that's, as an allergic kind of a guy, when I find that I get inflamed from a cold, maybe, or if I'm kind of semi-stuffy and then along comes another problem, it just really sets me off. Whereas if you're really cool and really calm, when something comes along, it only raises you up this far. I think your philosophy is right.
And medical priming is what it's called.
Priming. I mean, there's a word
for it. That's the term, priming, yep.
Right, because they've shown that these cells are kind of they have a sleepy affective state, and then they have an upregulated state, and when they're like this.
The word priming.
Yeah.
So let's talk about treatment. The issue of treatment for this perennial kind of a thing is going to be a variety of different things. I mean, first the orals, then the steroid nasal sprays, and then the shots, right? Isn't that kind of the
Yes.
route that you go?
I would say that, but oral antihistamine, again.
Like Claritin.
That's not going to help the dust mite people, because there's such a lot of late phase reaction, we call it, but it's just stuffy, and the antihistamines aren't going to help the stuffy, so you have to go right away to the nasal steroids, and if you don't mind doing that the rest of your life, that's fine. You do the nasal steroids, and then if you want to get less allergic, then you do the allergy shots.
So avoid steroid nasal sprays, allergy shots. That's the order for the stuffy that is from the
perennial stuff.
From the perennial thing.
Yep.
Exactly.
All right.
Exactly.
We have a question. My allergies are bad despite taking my medicine. Some folks tell me allergy shots could help. What is involved, and will they help? And that's the question. How effective are allergy shots? And how expensive are they?
Well, I think I tell patients that I expect them to have about a 70% reduction in their symptoms. It'll be more than the medications. It's about a 5-year course of treatment, and the rest of the allergy treatments I do like to point out are the rest of your life. I think that it starts out twice a week and it ends up being once a month. You need to do it at your doctor's office. So you really do get a nice improvement in your nasal allergies and the asthma.
And the price of that for a year of treatment?
It's front loaded. I think that I tell it's like $4,000 to $5,000, I suppose. If you add 5 years together, that's the whole 5 years. And for most people, it takes about 2 years, and you're saving money because you're using less medication. Plus, you're not going to be missing work. You're going to be feeling better. So I think that's rough economics of it. Is after about 2 years, the Medicaid data from Florida actually shows that the state saves money after 6 months because of the improvement in their other illnesses, their ear infections, the sinus infections, the asthma flares up. Yep, all those. So it only takes 6 months for Medicaid to see a savings.
So somebody's actually taken this, because there was a lot of hearsay about this, but somebody's actually taken standard immunotherapy, that's the shots, and put it to a test, and that was Florida Medicaid. So they had their axe to bear was we don't want to pay for shots, and they came up with yes, we do want to. Yeah, yes, we do want to pay for shots because it saves money, and it's all the stuff that we talked about earlier. That is I'm not snoring at night. My family is not disturbed. I'm not getting sleep disturbed, so I'm fatigued all the time.
My marriage is better because I'm getting along with everybody, and I'm happy because I am not fatigued. And
if you're obstructed in your upper airway, and you talked a little bit about this, if you're obstructing your airway, that is a miserable thing. It causes us to do things that are bad, to go get nasal topical decongestants like Afrin that actually destroys your upper airway and gives you dependence and rebound and all that kind of thing.
I think we need to highlight that point that you just made. People use Afrin nasal spray or the 12-hour nasal decongestants. And I have them in my travel bag when I'm going on an airplane flight because I know that my head will implode when I'm driving or flying in sometimes. Do you have a problem with my use of it in that way?
No. Not at all.
Okay, so what about, when is it appropriate? Or how could a person use these very popular, I mean, they're everywhere.
I like the use in airplanes. I think that's appropriate. Diving, I think that's appropriate. I think it's appropriate for upper respiratory infections where you're obstructed and you're going to use it for 3 days. It says right on the bottle 3 days. You're going to use it 3 to 5 days for a viral,
for a cold.
For a cold.
Okay.
Upper respiratory infection. Not lower.
All right.
And so I like it for those things because you can breathe and you're going to sleep, and sleep is important.
Sleep is a good thing.
Yes, it is.
But if you need to keep doing it, you need to be getting looked at to find out what's wrong.
Yeah.
And we've talked about medications that if you get an upper respiratory infection and you're on antihypertensive, which dilates the vessels in your nose, you're going to have a tougher problem. You may be more likely to have to use topical, but at least you're not using the oral and raising your blood pressure tremendously.
I'm not a fan of oral decongestants, and I'm even less of a fan of the nasal spray decongestants. And I say to my patients, I mean, you're nicer to them. I say, you use this once a week max. You know, you can spray down if you're on an emergency basis, but that's it for the thing. And if you start needing that, you go right to the steroid nasal sprays.
But, you know, one of the things we've, again, talked about is salt water is a decongestant.
So you like saltwater sprays?
Yes, I do. I use it extensively in all formats, you know, syringes, bottles, neti pots.
The neti pots, let's talk about those. Do you like the neti pots?
I do if the person can stand the volume. I mean, it's a tremendous volume.
Well, I think sometimes that the pressure can be so bad it rams that stuff inside the sinuses and causes sinus pressure and pain and problems. What do you think of that? Mark, you had a...
I'd rather have the person bother using their generic Flonase for their allergies. It's hard enough to get people to do anything, and so I'd rather go to the one agent that would make the most difference.
So you push the steroid nasal spray?
Yep.
But it doesn't work immediately.
No,
but,
takes a little
but you
while.
have to use it.
Right.
I
And
mean,
the saltwater sprays is something that anybody can buy over the counter, and it's cheap, right? That's okay.
It's okay.
Not great. And it has a decongestant effect.
Yes, it does.
I kind of like that as a recommendation. In general, people can use that saltwater spray and not be hurt
Now, I've
by
never seen a study, though, just out of interest, maybe you have in internal medicine, where it says that the salt that you're putting in your nose is ever a problem with absorption or people that are on salt restricted. I've never seen anything.
Oh.
Don't know. Have you ever seen anything?
Oh, my thought is that we overdo the salt restriction. I have to say that I don't have, it's sort of like this water push that everybody says for patients. You've got to drink all this water, and it's all this really great thing for you, and people
diabetes and insipidus.
And it just I had a nephrologist on my show one time, and he said that's a bunch of hooey. There's no, if you're thirsty, drink. If you're not thirsty, don't push water. I think that's about in the same ballpark of the salt restriction. Now, there are people who I remember if they would read the salt package that has this much salt, they'd start wheezing and they couldn't breathe because they'd go into heart failure. I mean, there are people who are so sensitive. So I'm not talking about them.
You mean generally?
In general, I think we overdo it. And certainly the danger of salt, we do that for a treatment for hypertension, for example. We say cut out the salt. But we know that maybe a third or 20% of the people will actually lower their blood pressure restricting salt, and the rest don't have a salt-sensitive kind of a problem. It's a different problem, a different part of the body.
Okay, so
Good.
now we've talked a little about perennial allergy,
Yeah.
the dust mites, and so I'd like to talk a little bit about seasonal allergy.
Well, now we're talking, this is perennial is all the time, right? Perennial.
Dogs, cats, mites.
Right, and it's not annual, it's ennual, E-N, right? Perennial. Now we're talking about seasonal. Let's talk about seasonal allergy.
So seasonal allergy. We have a wonderful set of seasons in South Dakota. We have tree season, which is in the spring, and that's the majority of the trees, and we actually have a special tree, cedar, which pollinates very early, and the people that live in the pier and along the river, they have a lot more exposure to that cedar early, like February, March. So even though there's still snow on the ground, the cedar tree really doesn't care. Then we have our standard cottonwood. There's always a myth about cottonwood. Cottonwood, you always think it's when the cotton comes off, that's when it's doing its thing. No, that's a seed.
That's grass.
That's grass pollen. Grass pollen occurs when the cottonwood is seeding. Right.
You know what, I want to talk about seasonal allergy, but we have a package we want to talk about. Here's a very interesting case of a woman who develops an allergic reaction, and it's probably, and she discovered and figured out what the problem is. So let's have this package, and then we'll come back and talk about this, and then we'll go into seasonal allergy, because I love what you're saying, Tom.
Okay.
Sandy Madsen loves being with horses and doesn't mind the chores that come with the territory. But recently, something in the barn caused her to break out in an allergic reaction.
It started on my hands, and I got big red splotches, and it just burned and itched, and then it went on my arms and up my forearms and then on my whole body.
Madsen thinks that she has unraveled her own medical mystery regarding the cause of her allergic reaction.
My husband called me, so I changed clothes quick, and I left on the same socks that I had on, but I just changed my shirt and jeans. And then all of a sudden the itching stopped and the rash went away, and it stayed on my feet. So I thought, it's something, I thought, from out here. And then I got to thinking about it, and I thought, I bet it's the wood shavings.
Madsen suspects that something unusual got mixed into the mulch that she uses for horse bedding in the stalls. For now, she'll wear a mask and cover up exposed skin in order to work with this material until it's used up. These images are from another woman, someone experiencing an allergic reaction to a drug. Like Madsen, the allergic reaction covered this woman's body, but unlike Madsen, the cause of this reaction was a prescription antibiotic, not an environmental irritant. Yet another type of allergy is seasonal. The chief of the Laboratory of Allergic Diseases at the National Institute of Allergy and Infectious Diseases in Maryland says that seasonal allergies affect those who are genetically predisposed. Dr. Dean Metcalfe says that certain substances set off a chain reaction in the body.
And when you get exposed to these materials, say at ragweed pollen, then you develop IgE in your blood. That fixes to mast cells. When you're re-exposed, then that IgE recognizes the pollen or the ragweed, and these mast cells release chemicals, and you get allergies. If the chemicals are released in the lung, you get asthma and wheezing and cough. If they're released in the nose, you get what's usually called allergic rhinitis or hay fever. And if they're released in the skin, you generally get what's called hives.
Dr. Metcalfe says that there are a number of ways to address allergy symptoms.
There's a way to handle allergies, which is a kind of combination of avoidance. For example, people who have severe allergies may prefer to stay indoors at periods of time during the day with air conditioning on. Or when they mow the lawn, they might wear a face mask. So the idea is to avoid heavy pollen exposure in the times of day when that exposure is high. And then if that doesn't completely work, then there are some over-the-counter medicines, non-sedating antihistamines, that may help people with mild allergies. When the allergies become more severe, when you're really sneezing a lot of nasal congestion, where you may be set up to develop sinus disease, or if your asthma is particularly bad, you really have to go to a skilled provider who will then give you the right kind of medicines to get through the allergy season. When it's over, hopefully you'll be able to discontinue those medicines and go about your business.
Boy, that's, I enjoyed that, particularly Sandy Madsen's story about finding something that gave her this rash and discovering it and working it out. So tell me a little bit about what you think it was, Mark, and what's your take?
Yeah, it looks like she's got a contact dermatitis thing, so, you know, it's like the poison ivy, poison oak families of stuff. There are all kinds of other chemicals, though, that could get mixed in by accident that people get sensitized to.
So it was, they ground up some poison ivy in that batch, and she got sick from it. I mean, pretty sick. It was amazing, and she figured it out.
Sherlock Holmes.
Yeah, there you go. Any comment, Tom?
No, I think you guys are right on top.
All right. So, seasonal allergy. I mean, a little bit of seasonal allergy was there, and you were talking about, let's just in summary say, trees, grasses.
And remember, our grasses are wheat and corn, and those are grasses also.
Okay.
And so we have kind of an artificial timeline for pollination in that we have huge pollination when wheat pollinates a grass.
Right.
And we have pollination of corn, which is so heavy that it just drops to the ground. So it's really got to kind of walk through it if you're grass pollen allergic. But very sensitizing, grass is. And grass is interesting because if it gets wet, it turns to starch granules, which are more sensitizing and smaller and more able to penetrate. And then the classic thing was what Dr. Metcalfe was talking about, ragweed, that a great picture of ragweed there, that is seasonal fall sensitivity. And I want to make the point that early August, 1st of August till frost. But remember that each one of these allergies are built on a platform of the allergy before it, that priming effect.
Right.
So the reason that fall, autumnal, that you'll talk about, is that it's built on all of these
other seasons,
other perennial, tree, grass, and then we come into the ragweed, and it's a killer.
People are allergic to grass, so it primes you. And then we always think of the hay fever season as being horrible, but it's because of that priming.
So it's the grass more than anything. But which grass, and is there a timing of that grass? I mean, I'm thinking corn is later, and of course you said it falls to the ground unless you're walking through and hunting those birds that I like to do, and we all like to do. Well, but what grass, at what time, and is it any particular grass? If you're allergic to one, it's all of them?
It's all of them. And of course, we live on a prairie.
So there's a lot of grass.
And, you know, we have great grass. You know, we have got brome, and we have these great grasses for our cattle. I mean, that's what makes us famous in restaurants all over the
and so
world.
At the end of May, most of them just start going crazy.
So it's a grass
June
allergy.
and July, and then finally when things are drying up, they'll calm down.
But the tree allergies, you said that the grass starts with the cottonwood floating, but the tree allergies, it's when they're budding in the spring.
Actually, when they have the little catkins hanging down.
What are catkins?
They're little things that hang down before you even see the leaves.
Okay, so just before the leaves, and that is the tree allergy time. Is it different? Does it present differently in a human being than the grass allergy? No.
Same itchy eyes, itchy sneezy, plugged up nose.
Okay.
Might have some asthma.
And it's interesting that, and ragweed, is that the one that they have the huge pollen counts and they announce them in the cities that the
That's correct. Because the pollination of that particular weed is probably the top pollinator per weed. And so it is a huge pollinator, even though there may not be a lot of it. Grass around here is going to have higher counts because there's more grass. But ragweed is a huge, and it's very sensitizing. I mean, it's just like kochia is. That belongs to a different group. It belongs with the tumbleweed and the kochia, which has done fabulous here. And we have sagebrush as our other big pollinator.
You know, I looked up ragweed in preparation for this particular show, and there are a bunch of different kinds of ragweed. I mean, they look entirely different. Are they equally allergenic?
Yes. Yes, and when you look at their pollen, it's pretty much the same. You can't tell the
microscopically.
Short
allergenically, they cross-react almost
very easily,
100%.
So, and you test. So when you're doing skin testing, and that's the thing that you mainly do, is that the thing that really triggers? I mean, that gives you the best idea of what people are allergic to. I mean, is that how you?
It's probably our first or second most common positive. And when it's positive, it tends to be a striking positive, right?
And what's interesting is the allergy antibodies are in our skin. So if you have terrible hay fever season, it's not that we make our allergy only in August. I mean, you have the allergy antibodies there, and it's only when the ragweed stuff comes out that we see it in the people. So it's like having a cat allergy, and as long as you're not around a cat, you don't have symptoms. Then the next time you're around a cat, boom, it goes again.
It hits. So I heard you both say the first frost. And then I've heard, though, in other shows, and I don't know which one of you two said it, but I think one of you said, it's just, we say first frost, but it's the time of the year that it just kind of dwindles. Is that true, or is it truly the first frost?
Depends on which allergen. You know, the ragweed, it's how many hours of sunlight. Of course, if you kill it off at 26 degrees, you'll stop it also.
Yep.
And if it's too dry, everything kind of just dies off too.
So this is a perfect example these last 2 years. Last year, I was counting on our hospital. I actually had a counter on the hospital, and it just burned out. There was just a day there wasn't any more ragweed, and there was no frost. Whereas in another year...
Yeah, I mean, it was a late frost last year, wasn't it?
Right, and the ragweed fully pollinated and
did its thing,
and it was done. It was just
the sunlight
pooped out.
got too short. Poof.
Right, gone. So, and then now this year, in Aberdeen, we had a pretty good little frost, but not 26 degrees. So the low parts, probably the ragweed took a hit there. So the count probably went down significantly. And remember, these are all windborne. So you always have to put that element of how much is it blowing? Because if it's a very windy day, you're going to have a lot more symptoms.
Yeah, at least 50 miles.
Yeah, exactly.
Yeah, the wind blows 50 miles typically.
The pollens go at least 50.
Goes 50 miles.
Yeah.
Jeepers. All right. Well, what do we need to talk about more on this particular topic?
Well, I think we should kind of segue into asthma, which is a part of this whole allergy profile. Because if it goes into your lung, now you're going to get that same reaction that you have in your nose, except it's going to be in your lung.
All right. And as an asthmatic, as a kid, I was an asthmatic as a kid, and I'm still kind of an asthmatic. I'm very sensitive to this topic. There is a lot of treatment that people provide for asthma. The biggest is that rescue albuterol inhaler. Provenal is one brand. There's a variety of those. And there was recent data within the last 5 or 10 years that said that people who use a lot of albuterol die sooner. There's more death in that group. These are called beta agonists. And then they came out with a long-acting beta agonist. For the longest time they said that they are not as bad, but now they're saying they can carry with it a risk of death too. And I'm saying this only not to say that we shouldn't use those meds, but there's a cautionary tale here. So let's hear that cautionary tale, Tom.
Well, the beta agonist we call a rescue. In other words, when you're actively wheezing, this is a great medication because it reverses the spasm that you have.
So asthma is a spasm of the bronchial tube.
That's one piece.
And you can reverse.
And there's a swelling part that's there too.
The inflammation.
Part. Okay, so there's inflammation and there's bronchospasm. And the albuterol reverses the spasm but doesn't touch the inflammation.
Yep.
That's
so remember, swelling and squeezing.
Two different things.
Yep.
Swelling and squeezing.
And the inflammation, just like you have noted, the swelling has an effect on the reactivity. How long will it take you to squeeze down? And we even have a test where we challenge you with something that is a chemical that measures how reactive you are. If you have a lot of inflammation post-exposure to some seasonal or perennial antigen or an upper respiratory infection, you're way more, meaning that it takes a very little amount to make you wheeze. So you go to run, you wheeze immediately. You may even be so sensitive, so reactive, that just going to sleep causes you to wheeze. Yeah. That is not a good thing because are you going to wake up and get to your inhaler?
Yeah.
So I consider night asthma to be probably the worst of the asthma reactivity.
Hence. So as albuterol, beta agonist meaning adrenaline-like. Adrenaline-like medicine that we use as an inhaler. Then there's a variety of different kinds, but most of it is albuterol right now.
The good thing to remember is if you need your beta agonist albuterol rescue inhaler because you're having symptoms more than twice a week, you need to be doing something preventatively.
All right.
And
so we use it as a rescue, and I, as an asthmatic, I've got one in my drawer. I haven't been using it. I use it maybe 3 times a year. Okay, so I'm pretty good at that. The question is, if I need it once a week, I should start talking about the preventative treatment. What is that?
Well, if you're using it once a week, that's probably reasonable unless you're kind of bugged by it. But truthfully, an inhaled corticosteroid is the best thing. It helps better than anything else. It calms down that swelling.
So a steroid, and you can take a steroid pill, you can take a steroid shot, you can take a steroid inhaler.
And you want to do the inhaler.
There's a huge difference between everything you talked about, because one is in micrograms. That's the inhaler. Micrograms, that's very little dose. And the other's in milligrams, thousands of times more. So the side effects of growth restriction, bone loss.
All the side effects of steroids are almost not there with inhaler.
Right.
Correct.
Just the good part, not having the asthma, not going to the hospital, not dying.
That's a good thing. We like that.
That's
like
the
good part.
Yeah.
And one of the things that we see, and is always of concern, the reason they combined that long-acting beta agonist, meaning long-acting dilator, right, and the steroid, is because it was very easy to get people to use something that gives them immediate gratification. It's not easy to get people to use something that they don't feel it.
Yeah.
They don't, and this inhaled steroid, they didn't. And they did a study where they had counters that they didn't tell them they had, and they said, okay, we've got these inhalers, you use them. Oh, doctor, I hardly ever use my rescue inhaler. You know, they look at the counter and they've used it 90 times. Oh, I've used that
steroid.
Oh, I've used that every day. And you look on the bottom, 5 times.
None.
So they combined them.
And then that tricks them into using the steroid.
That's right. And so the increased use of the steroid, and you can see this in national statistics, caused a dramatic improvement in the number of ER visits, so it was great.
Right.
Then this information on the long-acting beta agonist not being good came out.
And then it came up again all the time.
Because they said, okay, we're not going to use these combined drugs. We're going to go back to that same one where compliance was an issue.
Well, all I can tell you is I had an experience with a patient. I said, I'm dropping the Advair as one of the combined drugs. I'm going to use a single Flovent steroid inhaler. Did bad. Not long after that. Just didn't.
You're not treating both the swelling and the squeezing. And there are some people who have rather bad asthma that need both. And so you have to carefully watch somebody if you step down the therapy. And periodically we want to do that.
Yeah.
If you're never having asthma, maybe you don't need as much. Something changed in you.
Right. So the beta agonist, that adrenaline thing, is very similar to this thing called the Epipen, right?
The beta agonist,
same family.
Same family.
Except
that the Epipen covers alpha, which gives you a lot more vasoconstriction. That's the blood vessels constricting, which is a part of that huge systemic reaction where all the blood vessels open up.
Let's talk about it.
That's not good.
We're going to switch to this package and talk about the use of Epipen in a child who has eosinophilic esophagitis. Now that's a different illness than what we're talking, but this child is also very, very sensitive, very, very allergic, and has periodic anaphylactic reactions. So let's listen to this story.
So he's had it really since he was born. We found out when we diagnosed what he had when he was about 14 months old. So it does cause anaphylaxis quite a bit, so EpiPens are a daily part of our lives. Everything basically causes an allergic reaction. He's able to have a total of 7 foods right now. We started using the EpiPen when he was about 14 months old. Right now, we're using them less and less because we're better trained at what to watch for. But I would say at least once every 3 months we're using it, and sometimes we might use it 3 times in 1 month. He knows how to EpiPen himself. He hasn't done it himself, but I have a 7-year-old, a 6-year-old, a 3-year-old, and a 2-year-old, and they all have practiced using the EpiPen and know how to use an EpiPen and understand what an EpiPen's for. It's kind of more probably the traumatic way that it happens versus even just the shot, because you have to do it pretty forcefully. Like you have to stab really hard. If you just stab lightly, it doesn't go in. So you really have to like kind of violently stab really hard. So just the action of somebody doing that really quickly and stabbing you in the leg with it, I think the suddenness of it is painful for a couple seconds. Within the first couple minutes, you already start to see like a breathing ease. Sometimes we've had a situation where we've had to do it twice, or we go to the emergency room often after we use it. For example, we have the lifestyle or his type of disease that we have, like 6 of them, because we have one in the car, one at daycare, one in my purse, one on him all the time. So, but it's covered by insurance. We did have an anaphylaxis once when I didn't have an EpiPen on me, and that was it was very scary. So in some ways an EpiPen I think is a miracle, because I don't think Gideon would be able to survive or live 100 years ago or 50 years ago. The EpiPen gives him the freedom to have a normal childhood and gives us the comfort of knowing that we can help him if he needed it. They do expire. And so when you get an EpiPen, make sure you ask for, like, I've gotten EpiPens where they'll expire in 30 days. And so now I know to ask for the EpiPen that's not on the front of the shelf, but on the back of the shelf that has a 12-month span in it. So you do have to renew your EpiPens and look at the expiration date on them.
Wow, that's such a story about EpiPens. Any comments? I mean, I think that we underutilize them. I mean, she's had an experience. What's the danger of using an EpiPen? Could it kill your kid or cause a problem?
Actually, the problem is if you don't use it, you might die from your food allergy or anaphylactic reaction thing. And the worst thing that happens is it feels like somebody scared you.
So that's the worst thing.
Yeah.
And so if you get an EpiPen and you're reluctant, but you're thinking you should use it,
you should have used it already.
How about just taking a Benadryl and maybe get by without using the EpiPen?
You'll still die, because the Benadryl won't work fast enough, doesn't do the right thing, because it's the vasodilation, meaning the blood vessels just open up and the fluid is just flowing through them. And what the epinephrine does is it closes them up and
brings your blood pressure back.
That's right.
And in 30 to 60 minutes, you'll be sleepy and less itchy if you've lived that long.
Yeah, if you're using the Benadryl. So we need to have EpiPens. We need to use them if there's even a hint of a possibility of a problem.
If the throat is swelling, you're having problems breathing, you're feeling faint, or even if you got a bunch of hives and you know that it progresses and it's getting worse even before it hits, you might as well give it.
If you're getting hives.
Yeah. Well, if bad hives and you know that it progresses onwards, just general hives you don't need an EpiPen for. And once you've given the EpiPen, it only lasts its effect about 15 minutes, so you want to give and then go to the ER so that they can give you more and manage your airway and such.
We have a special problem in South Dakota, and that is our kids are not usually 5 minutes from the hospital. I mean, when you live in Aberdeen and you serve that area, there are a lot of kids that are 30 minutes from the time they recognize them. So they have several,
EpiPens.
or 3, because it is so safe. Remember, you make epinephrine in your own adrenal, so this is not, you don't make it quite in this dose, but you're going to, when you get one of these reactions, you're going to squirt all of your epinephrine. So it's not an unsafe thing. I mean, the only myth that's come is people with cardiovascular disease and older people, and you're going to die of hypotension a lot faster than you are of the vasoconstriction from EpiPen. So duh.
Yeah, I mean, of course, if the blood pressure is lowering because of this allergic reaction, and you aren't perfusing your heart
or your head,
I mean, you've got to get the Epi is a good thing. So we need, take home, huge take home lesson. If you are a hyperallergic person, get it available, and
you can go right
don't be
through
afraid
your
to
clothes.
use it.
I mean, we have right. We give everybody a trainer so that they can train their the other day
grandma.
Yeah. And I tell them always when they're at school to go through with the school personnel exactly what would you do if they had a reaction, so that the EpiPen is not locked in a drawer and the office and many feet away, those kinds of things.
What about teachers? Should we talk to them about, I mean, if they're teachers watching right now, what major lesson should we tell them?
They should learn how to use an EpiPen.
And have them available.
And have them available. I think the teacher should have the EpiPen, not locked away in the office.
Well, unfortunately, oftentimes they are locked away in the office.
It's the wrong thing, because you and I both have managed it. It happens fast, and you don't want to be going to the office looking for the key to the drawer that carries them. And those kinds of things.
If you're an emergent basis, you need to be ready at the time.
Because the sooner you use it, the more effective it is, and they've shown that over and over.
And you can use it for severe asthma. You don't have to have urticaria. If you're having a bad asthma attack, EpiPen.
EpiPen works.
All right. So we have an essay coming up about stuffy nose. I think we'll take that, and then we'll have some response from you guys.
Thank you.
Especially at this time of the year, many people struggle with stuffy nose and upper airway congestion. Although the stuffed up experience can be due to reflux esophagitis, deviated septum, reaction to medication, or even bacterial infection, when we experience such autumnal mucus excess, we are usually reacting to ragweed pollen allergy or to the epidemic viral infection or cold that happens each fall when kids return to school, or both of these maladies. Whichever, a stuffy nose can be miserable, and so effective treatment would be nice. Of course, prevention is the best plan. Most allergists advise that in order to prevent allergic rhinitis, one should keep the windows closed and the air conditioner on, start allergy medicines at least 2 weeks before the symptoms occur, and stay indoors during high pollen count days to avoid exposure to that airborne stuff that makes us sneeze. Prevention of the common cold is different. Most physicians advise keeping hands out of the eyes and nose so as not to acquire the infection that most certainly is smeared all over every hand. Remember, the infectious stuff is everywhere we touch this time of the year. Just picture all sorts of tiny bugs living on your hands, so you will more readily find every excuse to wash them. To treat stuffy nose from any cause, really, steroid nasal sprays and even saltwater nasal sprays can give relief. If it's allergic, over-the-counter antihistamines also can help. Loratadine, also Claritin, can help. Again, if you know you're going to get an allergic nose mid-August through October, it's best to start these 2 allergy medicines a couple weeks before the season. Some recommend decongestant sprays or pills, but I am not a big fan of these as they irritate and they dry too much. They affect the mood. They cause overdependency. Other over-the-counter cold or stuffy nose medicines cause sedation, confusion, or a hangover. Zinc can cause loss of smell, and echinacea and other herbals have not been proven effective. I advise instead hard candy or cough drops, as the resulting saliva fights infection, causes swallowing, and helps clear the nose and throat of mucus. So if you have an autumnal stuffy nose, know that you will likely survive, and it will usually get better with time. But the wisest plan is to prevent the problem in the first place. We'll be right back. Gee, I sometimes think that guy is on the mark, and then sometimes he's kind of off. Mark, what do you think? Did that make sense?
You know, when you have the nasal congestion and problems, allergy is one of the things. There are so many medicines. There are structural problems in a person's nose, and I really like the approach of just deal with the symptoms. If things aren't going well, get looked at by your doc. You may need an ear, nose, and throat consultation. You may benefit from an allergy consultation and find out what to do. You know, what happens if your nose is just full of really dried secretions and stuff?
Clean them out.
Clean it out,
Get
like you were saying.
Yeah.
So, but we have really great treatments in 2011 now.
So seek out some help with your doctor.
That's right.
Whole show in front of behind you now, Tom. What comments? What did we miss?
I got my one pet peeve, which I'm going to do, and that's the decongestant pet peeve.
Okay.
I don't use decongestants. It's a stuffy nose.
It's that Sudafed.
Sudafed, Claritin D, Zyrtec D, all that D stuff. Number one is part of the reason people use it, they can't sleep at night because they've got this nasal congestion. So now they're going to take a decongestant, which it says right on there, it's going to keep you from sleeping. So it's going to compound that problem. And when they use it in the day, they're using it like coffee so they can stay awake because they didn't sleep well at night. And decongestant, if you're an older gentleman, you may not be able to urinate. So you don't want that to happen. So I'm not a big decongestant person. Nasal congestion that keeps you from sleeping at night is bothering your lifestyle, needs to be evaluated.
All right. So we've got 30 seconds. Any comment about Michelle Bachmann's anti-vaccination? What do you think about vaccinations in general? We've got just a word. Good?
Vaccinations save lives.
Vaccination saves lives.
You know, military, we gave a lot of vaccinations to save lives.
Gentlemen, thank you so much. Stay healthy out there, people.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.